our international delegate, Dr. Taral Nagda. He's a pediatric orthopedic surgeon, and he's been working with Sri Lanka for many years, and he's not a unknown person to many of you here. He is one of the top pediatric orthopedic surgeons with a special interest in management of cerebral palsy, hip preservation in children, and deformity correction in India. He has innovated techniques like percutaneous myofascial release for muscle lengthening in cerebral palsy and minimally invasive deformity correction. He had an outstanding academic career in his undergraduate and postgraduate education, and he learned art and science of children's orthopedics from San Antonio and San Diego, USA. He is the director of Jupiter Gate Analysis Lab and an active researcher with many national and international publications. He has a keen interest in gadgets and conducts an annual computer skills course for orthopedic surgeons and is the webmaster of the Pediatric Orthopedic Society in India. So over to you, Dr. Nagda. I also would like to thank you for coming all the way from India. Thank you.
My pleasure here. And a lot of people wonder, if it's a cerebral palsy meeting or a child development meeting, what is an orthopedic surgeon doing here? And this question is asked to me many times. Parents come and ask me, doctor, it's a cerebral problem. No, why are you required, or why are we referred to you? And let's try to answer this in next 20 minutes or so in the time which has been allotted to me. Saman Mali, if I exceed my time, please remind me as a efficient moderator and tell me that you are getting late, and I can stop there. So why do we need orthopedic surgeon to treat cerebral palsy? Yesterday we all knew that we cannot treat cerebral palsy. What all of us are doing, my previous speakers and everyone else in the audience, is our goal is to help the family and the child to achieve his or her maximum potential. And we have seen today, from the stars, what maximum potential they can achieve when a proper environment is, given to them. And this also tells us, in spite of difficulties, it's possible to lead a life which is peaceful, which is purposeful. And all of us are trying to do that. So patients will do well, not because of orthopedic surgeon, but in spite of orthopedic surgeons. And this is the reason why we are required. So all of us know the primary problem in cerebral palsy is possible a perinatal insult or a genetic insult. That's the primary issue. And that gives rise to some losses and some positive things, negative and positive thing. So what we lose is strength and you get weakness. What you lose is balance. What you lose is ability to carry on tasks for a longer time, which gives rise to fatigability. What you lose also are postural senses in cerebral palsy. It's not a pure motor problem. What you gain is increase in tone, though it's not a positive thing. What you gain is spasticity, what you gain is clonus, and what you gain is co-contraction. It's a very interesting phenomenon in cerebral palsy. When I bend my elbow, my biceps contracts and triceps relaxes. In cerebral palsy, somehow the children lose ability to do that. So hamstring and rectus would contract together and make it a stiff knee gait. So this is an additional problem which also happens in cerebral palsy. Now all these together give rise to muscles which are short, because bones continue to increase in length. Muscles don't continue as the child grows, and hence you get muscle contracture later on. And then bone torsions, joint contractures, joint instabilities follow. And you would realize that secondary and tertiary problems require an orthopedic surgeon to correct themselves. Now the whole term orthopedic surgeons is right and wrong. Okay, with orthopedic surgeons we mean bone doctors, but it's not really true. Orthos means straight and peds means child, and by that definition every orthopedic surgeon is a pediatric orthopedic surgeon. Now the word pediatric orthopedic surgeon is a wrong word. Like in India, we say thanda cold drink. The word cold drink includes, or people will say that, go straight in a straight line. So it means the same thing. So orthopedics means somebody who will straighten a child, not necessarily a mother or a teacher, but it can also be an orthopedic surgeon. And we don't just deal with bones. Actually, the name for an orthopedic surgery should be a musculoskeletal surgeon. And then that tells what we are going to do when we correct a child's deformity. So we saw this yesterday, that you can have 3 phases in a child's life. Child who is 5-year-old, he is walking on toes because of spasticity. Then you have a child who is also walking on toe and he is 8-year-old. But he is not walking on toes because of spasticity. He is walking on toes because the muscles now have contracted, relatively contracted. And then you have this third child who is 12-year-old, similar to some of the children which you have seen yesterday. This child is walking on toes with externally rotated gait because of a liver arm problem, because of bone deformities and joint contractures and rotational issues. So because the reason the child is not walking properly is different in each of these scenarios, the solution is also going to be different. So you have these 3 problems which are interrelated. So if you have increase in muscle tone or spasticity, you have to tackle that. If you have muscle contracture, you take care of that by lengthening. But if you have liver arm problem, you take care of it by, taking care of liver arm. In cricket is a funny game. Sri Lankans and Indians, we love cricket. And cricket, the funny rule is stump out. When you run out a person, whichever stump you hit is still out. But cerebral palsy is different. There are 3 stumps. One is a stump of spasticity, one is a stump of contracture, one is a stump of liver arm disorder. If the problem child has liver arm disorder and if you hit the stump of spasticity, it will be not out. Okay. If the child has contracture and if you correct liver arm, again, it's a wrong thing. You have to hit the right stump, and that's the game which we play in cerebral palsy. So you have to hit the right stump or, hit the right dart, then only you are correct. And how do we differentiate? Again, this is small revision that, this child has Tardu scale where R1 is 30 and R2 is -10. So we know that spasticity interval is 40. And because you are able to dorsiflex to 10 degrees, there is no shortening. This child needs control of spasticity by Botox or plaster or any other means. Now the second child has R1 of 40 and R2 of 30. So narrow spasticity interval. He has mainly shortening. So 1 kilo of Botox will not help. You need to lengthen this child muscle. Similarly, going to hamstrings, you have this child who has hamstrings R1 which is 30 and R2 0. So spasticity interval is 30. There is no shortening. So this child needs, there are 4 boards over here, spasticity control with help of botulinum toxin. And this child, again, working with knee flex, but has R150 and R240. Spasticity interval of 10 or 40, so it needs lengthening. Okay. So why do children need get spasticity? Because shortening, because the muscles which are under tension, they don't grow in length as much, and then you develop these effects of spasticity. How do you treat spasticity? Various ways. You can give medications, therapy, splints, a good environment, everything gives rise to decrease in muscle tone. This was a 5-year-old child, preterm, NICU graduate, developmental delay. With therapy, she is able to stand now, and this is how she walks. She walks with a scissoring gait. She walks on toes. She walks with knees bent. And on evaluation, we found out by applying this Tardu scale that her calf, adductors, and medial hamstring are spastic. In spite of therapy, she is not able to progress further. So how do we control this child's spasticity? Is by a process called chemodenervation, where we inject botulinum toxin in the motor end plate of the muscle. And these are the points. If you were to do it, just through eyeballing or surface marking, this is how you would inject in the calf and then in the hamstring. But what we use nowadays, and I'm sure that most of you have started to use this, is ultrasound guided injection of the botulinum toxin. Advantage of ultrasound guided toxin is it hits where it hurts. You are exact in the delivery of the drug, and the amount of drug which is required is less. So you can, in this economic crisis, you can save little money by using lesser drug, and also the volume of drug become less so that it is more, it's less painful for the child. Okay. So we do this, we do plasters for the child only if required. It's not compulsory that every time you do botulinum toxin, child needs a plaster, but if there is a deformity, sometime plaster will be required. The effect comes within 3 days, starts within 3 days. Maximizing of the effect happens within 3 weeks, but it lasts only for 6 to 9 months. But we have to utilize that time for therapy. So you can see this child after injection of botulinum toxin, the feet have grown apart. So spasticity of adductors has gone. So balance has improved. Okay. The knees are straight. So step length has increased. So in a given time, child is able to walk a longer distance. And the heels have come down so that instability is gone and child's fear of fall has reduced. So when you control spasticity, a lot of things happen. And as we've seen in previous talks, the neuroplasticity now takes over. And even though the effect of the drug will diminish after 6 to 9 months, the effect of the therapy will continue. And you don't have to really repeatedly give this every 6 months or a year. Most of the children, 30%, will not require a second dose of botulinum toxin. Some of them will require one more dose after 3 to 4 years. And very rarely you will have children who require annual dose of botulinum toxin. Especially it happens in children who are high involved or those who have dystonia. How do we treat muscle shortening? Okay, so muscles in CP are not strong. They are spastic, but they are also shorter and weaker. This is what we have discussed yesterday. And it's important that in the process of lengthening the muscles, we don't make them weaker. This is something which is very, very important. Muscle shortening leads to joint deformities, abnormal biomechanics, loss of balance, and also secondary effect on the bones. Like how a wife would control the husband, the muscles do control the bones, and that shows in that relationship. What is behind the deformity? This is something which is very important to realize, how muscle tightness in one joint can lead to effect on other joints. So you have a child who's walking on toes, and this is true equinus. Now this child, there is nothing wrong with the ankle, still the child is walking on toes. The hamstrings are tight, the knee is in flexion, but the heel is lifted off and child is walking on toes. Ankle has a problem because knee muscle has contracture. If there is a equinus at the ankle, on the other hand, it leads to recurvatum at the knee joint. Okay, so it's important to realize that one joint muscle shortening can also affect adjacent joint, and that's why what we feel is muscle shortening should be treated as soon as you come to know that it is not getting corrected with therapy, it's not responding to botulinum toxin, it is not responding to splints. Don't wait. Correct this muscle shortening as early as possible. So this is the social situation, ma'am, of cerebral palsy in India and Sri Lanka. You can see this child is walking with inverted feet, with knees flexed. The entire load is carried by one parent. Which is that? The mother. And what is the father doing? Standing coolly. His presence is felt, but he's not doing anything. There is no responsibility. Okay, this is how the child walks. The hamstrings are tight, tip post is tight, and calf muscles are short. And in this child, what we do is PMFR. So I'm just going to explain to you what is PMFR. It is releasing the aponeurosis of the muscle under ultrasound control using small needles. So when you release this aponeurosis, the muscle length actually improves. And these patients are put in plaster for around 3 weeks. And this is how this procedure is carried out. You see a gastrocnemius here, and you can see my needle. Can you all see the needle here? This is the needle which is carefully teasing the aponeurosis and cutting it. And this is in another view, you can see this needle is cutting the aponeurosis, and you can actually measure the amount of lengthening. You cannot over lengthen this with method, because every lengthening will give rise to 5 to 7 millimeter of length of a muscle. So this is how this is done. And this is the child after therapy. After around 3 months, she is able to walk independently. So from GMFCS maybe 4, she's brought on to GMFCS 2. And then this is not a completely normal gait pattern, but she is now ready to go to school. And you can see the mother is freed now. When you make a child to walk, you are freeing a mother. And then you can see the father, who was at a corner, suddenly comes after because he sees a hope. that my child is finally capable of doing something. Maybe she'll win a star award at the next meeting of the Sri Lanka Child Disability Association. So another child, this is a jump gait, okay? Calves are tight, hamstrings are tight. Very difficult for therapists to, get this child to walk a lot of steps. Very difficult for us to send this child to the school. And this child, let's finish. So this is the video of the child before the procedure. We always see them with the braces on, and after this procedure, you can see the child is able to stand with the heels down, knees straight. So we have not improved cerebral palsy. I have not treated cerebral palsy. We have not done anything to the child's brain. By lengthening the muscles when they were short, we have improved the alignment and have caused these children to walk better and to be more confident, to be able to achieve their education, their hobbies, to associate with the peer group. So if you see the international classification of function, by changing body structure and function, we are ensuring better activity and participation and better coordination with self and environment. So that is what happens when you do an orthopedic intervention. Another child walking with knee flexed, and this is the result of hamstring lengthening with PMFR. So this is a procedure, if done well in time, helps us very quickly going through liver arm disorder. If you have to lift this, it's difficult, but a liver will help you. But when liver goes wrong, here you have applied a liver, but liver is at the wrong place and you are not able to lift. And this happens when liver goes wrong. And finally, if you correct the liver, once you correct the liver, it will allow you to lift the stone better. So this is what a liver arm surgery does. Again, it does nothing to the person who is lifting it, but it makes it easier. So similarly, if you have a liver arm disorder in a child with cerebral palsy, it causes difficulty in walking like this child. And then by correcting his crouch gait, by correcting the livers, by bony osteotomies and by elongating the tendons, you make him to walk. And when he walks, a lot of things happen. I have shown these slides yesterday. You have peer group, participation, activities, social activities also improve in these children. Very quickly showing results of upper limb, because this was requested to me yesterday. This child is not able to use the right upper limb because it is in flexion. And what we did is muscle release and lengthening surgery. So along with that, we did a tendon transfer. Okay, and what happens is when the wrist goes in right position, this hand which was not able to do anything becomes an effective supportive hand. Okay, so that's the power of tendon transfer. This is the Shui score, which was spoken about. So you can see before surgery and after surgery, removing money from the wallet, which is a very economical, very important activity, is now possible for this child. And then when that is not possible and wrist is in bad deformity, even fusing the wrist can improve function of a child. So a lot of things can be done even for upper limb. Just let me quickly finish this. Okay, so this girl who was not able to do anything now runs a social media business from her home. Hip surveillance has been spoken about. Don't forget the hips, because children with cerebral palsy, especially non-walkers, can have a hip dislocation, and it's very difficult to treat when it's detected early. In fact, some of the children like this may even require removing the hip. It is so painful. But it's always possible to reconstruct. This child had a painful hip. This girl, 25-year-old, working in a call center, but she was not able to walk because of hip pain at the age of 25. And we preserve the hip. So the mantra is to preserve the hips and not to come in the way of the disability. So it requires a lot of people to pull the cart. You require orthopedic surgeons and developmental pediatricians and rheumatologists and therapists and everybody, working together, ONP, orthotic, prosthetic, everybody working together to achieve this. We have to have teamwork. So what orthopedic surgeons also do is they build up teams so that teams can work. We reach out, and I've conducted camps on buses and trains and all places so that the awareness about cerebral palsy and its management. Today our minister spoke about reaching out to the society, and that's something which is very important. it's also important to advocate. We cannot be apart from the governance mechanisms and the political forces. We have to align with them so that we can, bring out better legislation and money for affecting the children. It's important to train, learn, and collaborate. And I'm sure that this effort, this is the 6th meeting which is happening here. The effort which has been put by a few people for the Sri Lanka Association of Child Development. This is in infancy right now, and I'm sure it will mature more with time to come. And I'm happy to come back when I'll grow old and this organization would be still young, and seeing fruits of a labor at that time. Thank you very much.
දරුවා ඔබ සමග සිනා නොවීම, ඔබ දෙස නොබැලීම ඕටිසම් තත්ත්වයේ ලක්ෂණයක් විය හැකියි. ඕටිසම් ලදරුවියේදීම හඳුනාගතහොත් හොඳින් පාලනය කළ හැකියි. නොපමාව අමතන්න 1174093 SLACD සහ CDB සාමූහික මෙහෙවරක්.
If your child does not smile or make eye contact with you, it could be a sign of autism. Autism can be successfully managed if identified at an early age. Call our helpline on 0117490000, a joint effort by the SLACD and CDB.
குழந்தை உங்களை பார்க்காமை, சிரிக்காமை ஆகியன ஓட்டிசத்தின் அறிகுறியாக இருக்கலாம். ஓட்டிசத்தை சிறு வயதிலேயே இனங்கண்டு கொண்டால் அதனை கட்டுப்படுத்தலாம். தாமதியாது அலையுங்கள். 0117 490 0000. இது SLACD மற்றும் CDB இணைந்த செயற்திட்டம்.